Hey guys, this is Huzefa Bhopalwala. I'm a PGY1 resident in Eastern Kentucky. I recently did a talk on atrial fibrillation, just sharing my presentation. Hope you guys enjoy it. So, Does the Chaos Ever Settle is also one of my poems that I wrote back in the day in second year of med school. And yep, hope you guys enjoy it. So let's start with the case. 77-year-old woman comes to the ER with complaints of rapid heart action. She says she's got high blood pressure. She can feel her heart going really fast. She's got nausea. She's feverish. She's got cough. Past medical history is significant for hypertension, atrial fibrillation, osteoporosis, benign MGUS, osteoarthritis. She's on warfarin, that's Coumadin, metoprolol, digoxin, simvastatin, and she's got no known allergies. She's alert, oriented, to time-place person. Her blood pressure is 177/88. Heart rate is really high, 135, 150, irregular rhythm, clear lungs, 2/6 harsh systolic murmur, no edema. ECG shows atrial fibrillation, INR is 2.7. So in addition to continuing home meds, what would you do out of these 5 options? Begin IV diltiazem to establish rate control, give IV digoxin 0.25 one time to establish rate control, check digoxin level in AM, metoprolol 5 milligram IV and additional doses as needed, Q15 minutes to establish rate control, begin IV amiodarone to establish rate control and restore sinus rhythm, measure temperature, review chest x-ray, order urine analysis and blood cultures, fluids, acetaminophen. So basically the first few options are just trying to control the rate. Let's give you guys a little more information. So atrial fibrillation is permanent in this lady. Her heart rate and BP are normally well controlled. Home temperature was 101 degrees when she came into the ER this morning. She took an extra metoprolol, 50 milligrams, but it did not work. So what do you guys think? I'm going to go back to the slide and give you guys a minute to think about the option, and then we're going to see what the answer is, okay? So these are your 5 options. Okay. So basically, she was on anticoagulation, she was on antiarrhythmic and rate control, and it still didn't do anything to her heart, right? So sometimes what happens is there's an inciting event. You have a fever, you have a UTI, you have some kind of infection going on in the body that can make your heart rate fast. It can cause sinus tachycardia in someone who's prone to having atrial fibrillation or who has permanent atrial fibrillation. It can just incite an event as well. So measure the temperature, review chest x-ray, order urine analysis and blood cultures, give fluids, and see if these supportive measures help to bring her rate down, because it wasn't being controlled on her rate control medications, even when it was amped up. So this takes us to what is the physiology of fast heart rate. There are striking similarities in AFib and just sinus tachycardia or sinus rhythm and going really fast. So fever, pain, anxiety can do sinus tachycardia. It can also incite an event of AFib. Sepsis, volume depletion, postoperative state, catecholamine excess, endogenous or exogenous, degree of AV node conduction. So atrial fibrillation depends on how much the AV node is going to conduct, right? AV node, as we know, is the gatekeeper of the heart. And whereas the sinus rhythm, it depends on the SA node responsiveness, meaning how fast the ST node will keep triggering, will keep uh, giving out a rhythm. So is the atrial fibrillation causing acute hemodynamic disturbance? Maybe yes, maybe no. So if it's acute in onset, if you've already got structural heart disease, thick and stiff ventricles, very low EF, um, acute episode of AF can make you quickly decompensate. Why is that? One of many reasons is because it does not let you pump out as much blood, so you really lose your ejection fraction. So AF causes CHF at that time, an acute exacerbation of CHF. Maybe no. Chronic or permanent atrial fibrillation, because you've achieved hemodynamic stability and homeostasis, it doesn't really affect anything. No structural heart disease, again, AF is unlikely to cause hemodynamic disturbance there. Decompensation, if you've got any kind of decompensation, suppose you've got CHF and you've got an acute exacerbation of CHF, sometimes that can lead to atrial fibrillation. So this is a case of what came first, chicken or egg. So AF can cause CHF in an acute exacerbation, and vice versa, an acute exacerbation of CHF can cause AFib. So designation of atrial fibrillation. How do we define atrial fibrillation? So there are 3 P's. Paroxysmal is greater than 48 hours, but less than 7 days. It's basically in and out of it spontaneously. Persistent is it occurs spontaneously, but does not typically revert without cardioversion. And permanent is, earlier there was a term called chronic persistent. We no longer use that. Basically, it's 2 ways you can get that. 2 personalities are involved in making that decision. It's the patient and the doctor. So basically, when you attempts at achieving, maintaining normal sinus rhythm are not sought, and you're continuously for more than a year at least, or in permanent AFib, that's called permanent. So temporal varieties of atrial fibrillation. There's intermittent and there's non-intermittent. So intermittent has things called as paroxysmal and persistent. We already discussed what paroxysmal, persistent, and permanent were. What I'm going to talk about is a little about micro-atrial fibrillation. So classically, the definition of atrial fibrillation says that it requires at least a timeline or a time window of 30 seconds. This was reported in the STOP stroke trial. This was a trial of greater than 5,000 patients, and micro-AFib was defined as a rhythm strip of showing atrial fibrillation for less than 30 seconds. So according to the European Society of Cardiology, guidelines for AFib says that the definition of AFib at least contains 30-second time criterion based on consensus. So if it's less than 30, and if you still see AFib, that's called micro-AFib. So in a minute, we're going to discuss why that's important. So micro-AFib as a risk factor for atrial fibrillation. So as we spoke about the stroke stop study, it was around 5,000 patients. And what it looked at was the rates, how much time micro-AFib was there, and what was the risk of a patient having micro-AFib developing atrial fibrillation in the long run, any one of those types, paroxysmal, persistent, or permanent. So basically, whether micro-AFib was progressing to what we know as normal AFib. So after 2.3 years of follow-up, Micro-AFib group, 27 of 54, that's 50%, had developed the classic definition of AFib. And control group, only 5 of 48, that's 10%, had developed AFib. So identification of paroxysmal atrial fibrillation, subtypes. So there's this thing called, there are two concepts of legato and staccato. So what do these mean? Legato means the episodes are few, but duration is longer. So this on the y-axis is the mean duration, if you can see my highlighter here. And on the x-axis, it's paroxysmal atrial fibrillation events per day. So what is legato? Legato is got more duration, but very few episodes. In contrast, what's staccato? Staccato's got more events per day, but of lesser duration. So duration is less, but there are more events per day. So these are two subtypes called staccato and legato. We do not know if these differential forms of AFib might contribute the same burden of AFib or have an impact on outcomes like stroke, mortality, and likewise. And also, if you just, this also, guys, this becomes important also when you monitor the patient for AFib. There are a lot of new devices, and there are smartwatches which beep when you get an irregular rhythm, and then you can contact your provider, and they send an EKG patch. You can see the EKG and see if they really had an AFib or not. So why does this become important? Because if you just monitor for a very short time, what you can miss out is on legato, because legato does not come frequently. It's just the episodes are very few. It's just that the duration is longer. The y-axis here is longer. Okay, moving on. So rhythm monitoring strategies for detection of atrial fibrillation. So this is something which we already spoke about. It's called the legato in blue, and those are few episodes of longer duration, and staccato, which are frequent episodes but of shorter duration. Pattern of AFib and stroke. So this was a study done evaluating the Aviros and the Active A databases. So Aviros was one of the landmark databases, which the clinical question of the Aviros study was, in patients with AFib thought to be unsuitable for anticoagulation with a vitamin K antagonist, does apixaban reduce risk for stroke or systemic embolism when compared to aspirin? Also, how does apixaban compare to aspirin in rates of major bleeding? So this was basically the database, the Aviros study. So this pattern of AF and stroke just used this database to get AFib patients. And what they found is that in patients with atrial fibrillation thought to be unsuitable for coagulation with a vitamin K antagonist, apixaban significantly reduced risk of stroke and systemic embolism without increasing risk of major bleeding or intracranial hemorrhage when compared to aspirin. Also, now what we're going to notice is that when you break AFib into the three different types, permanent, persistent, and paroxysmal, what's the relation between each type and outcome of stroke? So permanent was found to have almost double the risk of stroke compared to paroxysmal. You can see the permanent here has cumulative events double the amount paroxysmal has. So if you have, basically in simple language, if you have permanent type of AFib compared to paroxysmal type of AFib, you're twice more likely to develop a stroke. Very interesting study. Okay, this is a quick question for the crowd. What duration of AFib recorded on a pacemaker or intraloop recording is best associated with occurrence of stroke? I'm gonna give you guys a minute there to think about this. So this is actually a trick question because, to be honest, no one knows. So there was this trial called the ASSERT trial, and what they found was, basically the clinical question, the background of the study was that 1/4 of strokes are of unknown cause. They're called cryptogenic strokes, and subclinical atrial fibrillation may be a common etiological factor. That's what they hypothesized. And pacemakers can detect subclinical episodes of rapid atrial rate, which correlate with EKG documented AFib. So they evaluated whether subclinical episodes of rapid atrial rate detected by implanted devices, if they were associated with an increased risk of ischemic stroke in patients who do not have other evidence of AFib. So very interesting study. And what they found was that the relative risk was more than twice for ischemic stroke and systemic embolism in patients with subclinical rapid atrial rate, rapid atrial tachyarrhythmias. Whereas in clinical atrial fibrillation of flutter, which was already diagnosed, it was 5 times, the relative risk was 5 times. So that makes sense, but what was new and what was interesting is that even subclinical AFib, patients with no history of AFib, you put in a monitor in them, you follow them for a period, and if you detect any rapid atrial tachyarrhythmias, for that matter, they have almost more than twice the risk of developing an ischemic stroke or systemic embolism. So that's what was very interesting about this study. So sub-analyses from the same trial, from the same study, showed that almost all the events, so it depended on the duration of how much time you have that AFib for. So the categories were greater than 6 minutes to 6 hours, then 6 hours to 24 hours, and then greater than 24 hours. So sub-analyses from the same study showed almost all the stroke events took place in the group which had greater than 24-hour duration. So basically, if you have it for a longer time, if it stays there for a longer time, you're more likely to develop stroke. Okay, so this is one more interesting study, one more interesting trial. It's called the CAPTAF randomized clinical trial. So basically a short description of this trial was that the goal of the trial was to evaluate catheter ablation compared with pharmacological therapy among patients with paroxysmal or persistent atrial fibrillation. So a total, it was a small study. There were only 155 patients who had failed at least one antiarrhythmic drug, and they were randomized to catheter ablation versus optimized pharmacological therapy. So the principal findings of this trial were that primary outcome, general health score at 12 months, improved significantly more in the ablation group. So basically what it meant was that if you get your AF burden down with catheter ablation compared to your normal antiarrhythmic drugs, it kind of significantly improves the outcomes, general health score, and the quality of life. And the p-value was significant. There was no reduction in AFib burden with catheter ablation versus pharmacological therapy. So there was no significant decrease in the AF burden with catheter ablation compared to pharmacological therapy. But their outcomes in terms of general health evaluation and general health score at 1 year was significantly better in patients who underwent catheter ablation. So here we can see the same thing. Catheter ablation, it shows the general health subscale score, and the ones who underwent catheter ablation had better general health score compared to the ones who underwent antiarrhythmic medications. But again, to reiterate, there were no significant or statistically significant, if I may say so, changes in the atrial fibrillation burden of AFib compared in two groups, the catheter ablation versus just medication. One more question for the crowd. Which wearables give the best quality information about atrial fibrillation burden? Is it, so there are 5 options, take a minute, and we'll get back to this. Okay. So here we have some new smartwatches. Different companies have introduced them. Here you can see the Apple Watch, if you guys can see my head. Then in the middle on the top, this is the Alive Corp, and this is the Cart Sky on the right. I'm not sure how costly these are or if insurance would cover them just to detect AFib, or I think it's just that people who have smartwatches and it kind of beeps when you have an irregular heart rhythm, and that's how they catch it. So there was an interesting study done on this. It's called the Apple Heart Study, and it had around 5 lakh patients. That's around 400,000 patients. And so what it showed was participants so basically what was the study design like, right? So participants without atrial fibrillation, as reported by the participants themselves, used a smartphone, Apple iPhone app, to consent to monitoring. So if a smartwatch-based irregular pulse notification algorithm identified possible AFib, a telemedicine visit was initiated and an EKG patch was mailed to the participant, and then they could put it on for 7 days. And then surveys were administered 90 days after notification of the irregular pulse and at the end of the study. So the main objectives were to estimate whether the proportion of notified participants, so they were wearing it, they got an irregular pulse, they notified their physician, they sent them an EKG patch, they put it on for 7 days at least. And so those people, if the objectives were to estimate that the proportion of notified participants with AFib shown on an EKG patch and the positive predictive value of irregular pulse intervals. So basically, how accurate were those irregular pulse intervals? So if they showed up, if they rang on your smartphone, did the story check out with the EKG as well? Did the EKG as well show AFib? So yeah, pretty interesting study. The results were skewed in the sense that if you see where my highlighter is, the more you wear it for, the duration of the longest episode, those episodes were captured frequently. So if you, so 1 hour episodes, 6 hour episodes, 24 episodes of AFib showed up more, because duration of 6 minutes and 30 seconds would only show up if you're wearing the watch 24/7. If you're not charging it, if you're wearing it even when you're sleeping. So these small episodes, like uh, an AFib run of just 5 minutes or 30 seconds, could be missed. And that's why on the study, it basically goes in favor of, it catches the episodes which were of longer duration. Makes sense, because longer duration would stick around on the smartwatch. Small duration could come and go, and you could miss it if you don't have the watch on at that time. Okay, so is the medical community prepared for wearable devices like these? This was another study published in European International Medical Journal 2020. So they did a survey and asked clinicians and doctors in the community whether they wanted their patients to be on this. And so the answers of the survey were, they weren't really comfortable with prescribing their patients with this smartwatch. What they said was they would feel more comfortable if there was a trial comparing sensitivity and specificity of every device in comparison to the gold standard. And I think that gold standard would be the EKG and the full workup for AFib and uh, all of that. So, yep, so there's still a long way to go until this becomes a reality. But with the way things are changing, especially with the COVID situation, and the entire world has become one small community, and telemedicine is picking up really quickly. So I'm thinking it won't be far away when we'll start wearing smart watches and instead of cardiac monitors, um, or in support of cardiac monitors or something, where a system is going to be just, if you detect something, call up your physician, set up a telemedicine visit, and take it from there on. So it might just become the norm and very in faster than we expected it to be. But that's what the physicians and the community right now feels, that we need more trials to have more support and evidence so that we can prescribe this out to our patients without any hesitancy. Okay, guys, with this, we're gonna take a quick break, and then we'll again continue with the presentation. Thank you for your time. Much appreciated.